What's going on, podcasting world? And welcome back to another episode of the Core Consult RX podcast. I'm your host, Mike Corvino. With me, as always, my co-host, Cole Swanson. I just made that up. You see that?
That's
freestyling.
Great. It's on the fly.
Yeah, that was terrible.
How's it going?
Good, man. It's been a while.
Yeah, holidays and stuff.
Ugh.
Time off, time with family.
I know. Actually, literally Christmas Day, my wife, Jen, was like, how come you haven't podcasted in a while? Hasn't been a new episode up to
She's getting on you for it.
Yeah, she's like mad at me for not podcasting.
So I'm spending time with you, babe.
Yeah, she's like, well, okay, but don't slack.
You really need to get one out there. You have all your followers and fans.
Yeah, all three of them.
Yeah, it's good. It's like 70 degrees at the beginning of January, so things are going well.
Yeah, they were doing the polar bear plunge yesterday over at Sullivan's Island. And
so not much of a...
Yeah, I ended up not even going. When I found out it was like 77 outside, I was like, it's not the move.
Yeah, I learned in the beginning of winter that my truck doesn't have heat. It's a new-to-me truck.
Uh-huh. Well, that's a cool feature.
Yeah, it's not great. So, yeah, I'm definitely enjoying the 70-degree weather on my long drives.
Yeah. I will say I'll take being too cold over cooking hot.
True.
Any day when it comes to...
Yes, that's true. So it's much better than not having AC in Charleston.
Mm-hmm. You show up to the clinic July, you look like a crackhead when you get in there because you're just covered in sweat. It's a nightmare.
Sir, do you have an appointment?
Yeah. No, I'm wearing a white coat. Oh, yeah, that's cute. Okay, let's get you right over to psych.
Yeah, my dad said I should just take it in and get it fixed. And I was like, maybe I'll just order a heating blanket off Amazon and call it a day. Yeah. So I did.
Did you really?
Oh, yeah. Works great.
Perfect.
Plug it right into the
that is 100%,
cigarette jack.
That is 100% a male
That's what I do.
strategy to that problem.
I spent half an afternoon. I think I figured out what was wrong with it, and I took off my whole front, stereo and everything came out, blah, blah, blah. I was like, I just need to get this part and fix it. Or I could just buy a heating blanket off Amazon.
That's perfect.
Yep.
It's the greatest solution I've ever heard. Oh, geez. I bet your wife's going to love that.
Well, she don't have to drive it, so.
That's good. Well, hopefully you guys don't have to take that anywhere.
Yes, we'll take her car.
There you go. All right. Did you see the new Pro Air inhaler?
Yeah.
Just got approved? The Digihaler?
You made a post about it, right?
Did I? I think I just made it like an Instagram story.
Instagram story,
yeah. But which was by me making it. I just took a screenshot of Medscape.
Spent a lot of time.
Yeah, a lot of effort and thought into that one. But no, apparently it keeps track of your inhalations and uploads it through an app, and it's kind of cool.
It's cool. So I guess your doctor might be able to see it and say, hey, you're not it's Pro Air, so it's not like something that you would want to be consistent with every day or anything, right?
No, but to me, I'm thinking if I was going to use that, and I'd say, hey, let me see the app
how many,
in your use,
yeah.
And I'm seeing you 18 times a day. Be like, okay,
maybe we need to increase your regular inhalers.
Right. Yeah. Get the controllers a little more on board. Because I've seen people that come in, they get albuterol constantly. Oh yeah. They get a new Pro Air inhaler every 5 to 10 days.
Right.
It's pretty sure you need to not be inhaling it this way, unless you're just using it to crush the treadmill a little bit longer.
Right. I'm really losing weight, doc. I need as many of these as I can get.
Stat.
Yeah, I saw a Grand Rounds presentation about some pills that kind of do a similar thing. When they're digested, sends a little ding to your phone, and you can track adherence that way, basically.
That's cool.
Don't know if there's anything out there.
That was Abilify, right? That did that?
Yeah, it was Abilify. Yeah, okay, yeah. That's what it was.
That's pretty cool. Some people are freaking out about that, but I don't know.
Yeah.
I feel like if they're going to spy on you, they're going to spy on you.
Yeah, I've got Amazon Alexas at home. They're listening to me all the time, right?
That's why I have to really watch what I say.
Yeah. Got to be really nice to my wife.
Super nice. Very, very politically correct all the time because you never know when Amazon's listening.
Yeah.
Anyways, what are we talking about today?
Conspiracy theories, apparently.
Anyways, Bigfoot. I saw him, right? And then he went away. I didn't keep my video footage. But, so we're going to talk about, obvious transition here. We're going to talk about Parkinson's disease and going to go through some of the basic background information, talk about the treatment options, kind of give one of our classic brief overviews. So nothing crazy in depth, but kind of go over some of these things and talk about some of the meds.
A couple of new things on the block.
Yes.
Right.
We got the inhaled
Inhaled.
levodopa.
Yeah, we'll talk about it a bit.
Yep.
Don't know how to pronounce the brand name, but
We got some debate over that.
yeah, we'll see. We'll tackle it 3/4 of the way through.
There you go.
So yeah, Parkinson's. I didn't realize how common it was, but it is considered one of the more common neurologic disorders, affecting around 1% of patients over 60. That's a lot, causing progressive disability. It can be slowed. There's no cure for Parkinson's at this point, of course, so it can't be halted by treatment. But treatment can hopefully. It's ultimately it's a clinical diagnosis. There's not great tests you can do for it as far as blood work and things of that nature. So usually it's somewhat insidious, and it's found because patients are presenting with the classic symptoms, which we'll go over. But as far as patho, it really comes down to a loss of dopaminergic neurons for reasons not always clear, but there's definitely a genetic component. It tends to run in families in some ways. It usually affects older patients, 60s, 70s or older, but can affect younger patients. So loss of dopaminergic neurons, specifically in the substantia nigra, and also presence of Lewy bodies. So protein buildups in those dopaminergic neurons are also a classic finding, usually post-mortem in these patients.
Yeah, and roughly it takes about 80% of the dopamine producing neurons to be damaged before these motor symptoms start to kind of appear. When we think about the actual motor symptoms, the major symptoms, there's an acronym I saw called TRAP. It was T for tremor, and that's can usually occur when a patient's resting, but then becomes worse if they become more anxious. And then there's the R for rigidity, usually in the legs, arms, can also be in the trunk as well, in the face. They call it like a mask-like face. Then akinesia, or also bradykinesia, would fall into that, which is a lack of or just a slowing of the overall movement. And then postural instability, which is more of to do with balance and can increase risk of falls. So TRAP is a good way to remember the major symptoms.
And frequently the gait or the posture is called that Parkinsonian gait. It involves them kind of hunching over, walking slowly with shuffling their feet. Also might have a softer voice than they used to have. Frequently will have sleep disturbances. A general weakness or malaise. They might be depressed. Their thinking might seem like it's slowed. So there's a lot of things that go into it, but the acronym is really the main ones that you're going to see. Tremor seeming to be kind of the hallmark, really.
Yeah. There's also, and we'll talk more about this when we start looking at some of the treatments, but you get into what's called the off time, and those periods of off time can extend as the disease progresses, and this is when basically the disease becomes worse before the next dose of medication. So in like an off episode that has to do with like muscle stiffness, slowing movements, difficulty starting movement in the first place, is definitely a problem and a frustration for patients having to live with this disease. And so we want to minimize that off time if possible. And so we'll talk, when we get into the meds, we'll kind of talk about that a little bit.
Yeah, treating these patients, it's really a quality of life situation, prolonging, or I should say delaying disease progression and prolonging time to late stage disease. And so reducing those off times as much as possible is important. We'll talk about levodopa being the hallmark of therapy, and within your doses you may have that off time. Patients might call it something like their bad time or their low time, even their shaking time or their slow time. I feel like I just entered a Dr. Seuss book for a second.
That was good. I was really excited.
Can rhyme sometimes. They might call it something like that, but you'll know it as the medication just not working as well as it should. And sometimes they may put the levodopa doses more closely together or increase the dose, but we'll talk about that as we go through the meds.
And kind of before we even get there, let's talk about some of the meds that can make it worse.
Sure.
We think about our antipsychotics, obviously, like first generation definitely would be a factor. Anything that can has a potential for like EPS type symptoms. We also worry about that with a patient that has Parkinson's. Prochlorperazine, other first generation antipsychotics, haloperidol. Then also our second generation antipsychotics, risperidone would probably be the biggest of those that can cause risk. Metoclopramide would be another one. You'll see that sometimes used in patients, and it's because it is renally cleared. It can definitely accumulate in elderly patients, which is who most commonly present with Parkinson's in the first place, and it can make it worse. So,
yeah, that's really the first thing you'd look at if you're having someone presenting with Parkinsonian symptoms. What could cause this? And once you rule all of those things out, it's you have to have 2 of the 3 cardinal signs: resting tremor, rigidity, or bradykinesia. If you got 2 of those 3 and you can't give a reason why that might be happening, then you could, tentatively diagnose them with Parkinson's and kind of go from there.
And you may be thinking, like, why bring up the antipsychotics? And, besides worsening the progression of Parkinson's disease, it's important because psychiatric conditions or comorbidities are very common with patients that have Parkinson's disease. So, depression is very common, which can be treated with, just a regular SSRI or SNRI. However, when these patients start going into more of psychosis is when we run into problems, because a lot of our antipsychotics, like I just said, cause worsening or potentially worsening of the disease. And so there's a few different agents that we can go to. Quetiapine, Seroquel, probably the least likely to worsen Parkinson's symptoms of those second generation antipsychotics. Then we also have things like clozapine, which can work, but then we have to worry about patients' absolute neutrophil count, and so we make sure they don't develop agranulocytosis. So that's not always a great option.
And very close monitoring that goes into that, and these patients' mobility is already limited, so trying to get them in for labs and stuff isn't necessarily feasible that often. So really, it's a consideration, but definitely would try for Seroquel first.
There's also another drug that it's been approved for a couple of years. I've never actually seen it. My wife actually brought it up to me before we started. But Nuplazid, are you familiar with that one?
I haven't seen it dispensed.
I've never seen it either. But it's a serotonin, specifically a 2A, 2C receptor inverse agonist. And it's approved specifically for hallucinations and delusions in patients with Parkinson's disease. So, it does come with some warnings, and if a patient is already on an antipsychotic for some sort of like schizophrenia or psychosis, it supposedly increases mortality when you add that drug to it. So there's a lot of other variables and things. We won't go into that too much, but just be aware that it's out there.
Yeah, so along with depression and potentially semi-psychotic symptoms, you can also have erectile dysfunction. Constipation is common. Daytime somnolence because of the sleep disturbances. You can actually use modafinil for that. It's not always like, hey, having sleep disturbances and you're tired, so let's hit you with some modafinil, but it's a consideration. That's actually something that they use in narcolepsy. You can just use polyethylene glycol for the constipation, and Viagra, something like that, is fine for the erectile dysfunction that may come along with Parkinson's. Those are some of the non-motor symptoms you might see. So
that's some background information. You want to move into the treatment options a little bit?
Let's do it.
See that?
I did see that.
By the way, I added sound effects back to the podcast, just so everyone's aware.
They haven't made an appearance in a while. I think that you did throw them in maybe 5-6 episodes ago.
Yeah, just so everyone listening can feel like you're a part of it. I was using an old iPhone that I no longer actually use as my phone.
Because he has like 7 iPhones.
That's not true. But I was using an old one to actually run the sound effects, and it kept having this weird like buzzing sound. And I think we recorded an entire podcast with that. I was so upset. I almost deleted the whole thing. But Cole in his cooler head prevailed and told me not to. So
don't throw the computer out the window.
Almost daily. But there was these weird humming sound. I couldn't figure out why. And then it was actually my younger brother was like, well, did you check the port that actually plugs the the auxiliary cord into to make sure there wasn't like dust or lint or something from her pocket down there. I was like, no. Yep, big thing of lint
Oh no.
down that. So no wonder it was humming because it wasn't making a good connection. So yeah, now we got that fixed, and
That's what was causing the humming?
Yeah,
No way.
that was it. Pocket lint.
That's hilarious.
This is how horrible we are audio. I literally have to watch YouTube for everything that we do here. So yeah, that was it. Pocket lint. Now we got sound effects again.
we there you go.
There you go, just like that.
Cha-ching. We advance week by week.
Yeah.
Pocket lint will not hold us back.
No, never. And it almost cost me a computer that was through out the window because I was so irritated. But we
That's
figured
hilarious.
it out.
First time I heard that story.
Really? And you heard it here, folks.
There you go.
All right, so I guess we'll start off with the primary treatment option, which is going to be your levodopa, also or often used in combination with carbidopa. Levodopa is a precursor to dopamine, and so we definitely want to replenish the levodopa in the system in order to, or I should say we should want to give levodopa so that we can replenish the dopamine in the system. Now, it is broken down in the periphery before it ever actually reaches the CNS, and so we give it with carbidopa to ensure that it can make it to the CNS. So carbidopa is actually going to inhibit an enzyme called dopa decarboxylase, and that way levodopa can actually get to its site of action that it needs to.
Yeah, and this combination is the mainstay of initial therapy, mainly for motor symptoms. That's what it's used for. It provides the greatest anti-Parkinsonian efficacy in moderate to advanced disease with the fewest acute adverse effects. If a patient's motor symptoms aren't the primary concern, there are situations where you might not start with this, but almost always that's the case because it's clinically diagnosed. Like Mike said, 80% of dopaminergic neurons might have to have died before you see these signs or symptoms. So very insidious, and that's why you would use this. There's a few formulations. Cinemet is the most common, and that's just that combination of levodopa, carbidopa. There's also a controlled release, and then there's a couple of other brands, Rytary, which are sustained release capsules. If patients are having trouble swallowing, this might help. Frequently, it's dosed a lot, depending on how a patient's symptoms are. And so it's a lot of pills to swallow, and within this, they might have issues swallowing in general because of their disease. So that's a consideration. There's also Duopa, which is an intraoral suspension, so they can't drink it. It's frequently administered by a portal pump into the jejunum over a really long period, like 16 hours. And sometimes it improves the on time and decreases off time that patients experience, which we talked about before.
Yeah. There's also the Rytary that Cole mentioned is definitely used more commonly now. It lasts a little bit longer than the other controlled release available options. However, it's only available as brand name, so it is quite expensive. So that's another factor to play with that one. But finding the right balance is super important to cut down on those off times, and that's where the new levodopa inhalation comes into play. Inbrija is the inhalation powder that's available now, and that's specifically approved for levodopa for the treatment of off episodes with Parkinson's disease. So that got approved on December 21st of 2018. So, way last year.
It's the newest kid on the block still.
Newest kid on the block.
So yeah, if you're taking your levodopa and you're having those off periods, then this is indicated for specifically that. You can use it. They estimate that about 40% of the 1 million or so Americans that have Parkinson's do experience off periods. So I guess there's a market out there for it.
Yeah. Some of the adverse effects to keep in mind, nausea, dizziness, orthostasis are common. Also dyskinesias, dry mouth can happen. It can also cause the urine to become black or dark. This would come into play, if a patient was on a statin, for instance, where we know that one of the adverse effects is, very rarely seen, but can happen with rhabdomyolysis. We would want to make sure that the patient your patient can differentiate between the other symptoms like muscle aches and things like that with rhabdo versus just a browning or dark color to the urine that can happen with the carbidopa levodopa.
One issue with the dopamine agonists, specifically levodopa, is that it's really a finite period of benefit that you see. So 4 to 6 years, or so around 5 years, is kind of what they say for how long you might be able to see good control of the motor symptoms. So sometimes patients might try to, it's a cost benefit type of thing that you decide with your doctor, and so they might try to push the levodopa back and say, okay, well, I'm going to wait a little longer until things are a little worse before I start, because I know that the benefit isn't going to last forever. Sometimes it lasts longer, sometimes along with some exercise regimens can improve how well the levodopa is working. But frequently that's why we have other adjunct therapies that can be used as monotherapy in some cases, but are frequently added on to the dopamine agonist to improve how well it's working.
Yeah. One thing I do want to mention too that I forgot to when I was mentioning adverse effects is priapism for males. So you want to be aware of that. And then also it can increase uric acid. So if a patient has a history of gout, especially with severe gout flares, or recurrent flares, I should say, be aware of that, because we want to make sure that we're not worsening that. And at least if we are going to have to increase the uric acid, we may need to go up on the allopurinol or something. All right, what do you want to go to next?
Well, there's a few other. Yeah, we could. There's a few other dopamine agonists as well.
You want to go to dopamine? Let's go to that. Sounds good.
So one is apomorphine, or apokine, not used as often, but it is a dopamine agonist indicated for the treatment of hypomobility, off episodes specifically, so end of dose wearing off, like we talked about. And it's it's actually a subcutaneous injection. Its exact mechanism isn't necessarily unknown, but they think it activates postsynaptic D2 receptors, and so apomorphine is not common, but can be used to help with off episodes.
Yeah. Did we already go through Mirapex and Requip?
No, so those are going to be the more common options that you see. They can be used as monotherapy or as adjunct if the levodopa is not working as well. Mm-hmm. But yeah, pramipexole is Mirapex and merpinarole is Requip, and we'll see those pretty frequently.
Yeah. So like you said, those dopamine agonists, some of the adverse effects that can be commonly seen with those, somnolence, dyskinesias as well, and then also orthostasis and potentially even hallucinations can happen, along with dry mouth and some of the other not as severe symptoms. But there's immediate release and extended release versions of pramipexole as well as ropinirole, and then Nupro is another dopamine agonist. It's a patch form that is available as well. It's a once daily patch. I don't see that one as often as the other two, but it's out there, and sometimes they'll use it for like restless leg, restless leg, as well as they will also do that with Mirapex and ropinirole as well.
Right. And so those are the things that you're looking at when you're trying to decide what to use, either as monotherapy or adjunct, or really side effects and where the benefit is going to be. So levodopa has fewer specified adverse events overall, with more motor complications. Dopamine agonists generally have fewer motor complications, but less improvement in the activities of daily living compared to levodopa, and more side effects overall. So that's the kind of thing you're considering before you use either ropinirole or pramipexole. Amantadine's another option. The data is really lacking with that one. It really would be considered more of a last line dopamine agonist, but it is out there. It's an NMDA receptor antagonist, whereas Mirapex and Requip are both considered D2 receptor stimulants.
Mm-hmm. The other option for, as far as getting the levodopa into the system, carbidopa is obviously the first option in most cases. However, there is another way that we can kind of ensure that levodopa gets there, and that's using a COMT inhibitor. So catechol O-methyltransferase is another enzyme in the periphery that can cause that levodopa to be converted in the periphery before it actually reaches the CNS. And so we can give that as well. So it's typically, and really only should be given with levodopa because that's the whole point of it. And there is cases where you can give carbidopa, levodopa, and the COMT inhibitor. Entacapone, Comtan is the medication by itself, and then there's a triple therapy all in one called Stalivo. So that's out there, and then the adverse effects are going to be very similar to that of the carbidopa levodopa combinations because obviously that's the whole point of it is to get more levodopa into the system. A lot of times when you add on that COMT inhibitor, you need to decrease the levodopa dose slightly. Sometimes 10 to 30% will be necessary when you're first adding it, and then titrate back up if you need to, because a lot more should get into the system, and you want to make sure you're not really increasing those adverse effects like the dyskinesias and whatnot.
Yep. So that's COMT.
Yep.
Other types of drugs you can use in monoamine oxidase inhibitors. So you might recognize these from your depression lectures. These are monoamine oxidase B inhibitors specifically. There are monoamine oxidase A inhibitors, so important to differentiate between those. I think Mike actually gave a little anecdote at one point about a drug interaction there, right?
Yeah, we did. Yeah, that was a long time ago.
That was
I think,
a while.
But we were supposed to do a whole segment on that, by the way. Remember?
I think we did.
We did.
Yeah.
And then I even added in, because I didn't have the cool soundboard back then, but I added in like a gong sound.
Did you really?
Yeah.
Well, might as well use it again.
What, this gong sound? Perfect. Nailed it. But we were talking about the venlafaxine. It was I think it was a student that had.
It was Morgan.
Yeah, that's right. It was Morgan. What's up, Morgan? In case you're listening. But she had sent me a text about that interaction with venlafaxine with Azilect, because it was coming up as an absolutely contraindicated interaction, and it's really the MAO A inhibitor that would be the interaction. We found some data that shows that, in theory, it's fine to do the MAOAIB inhibitor along with venlafaxine, but you'd probably want to discuss it with the patient and everything. But this patient's depression was finally under control, and they were about to stop the venlafaxine because of the Azilect. So, and they had been taking it fine for like 2 months with no problems whatsoever. And they were about to stop it anyway because of that drug. So
it's a good catch.
Good catch.
But these drugs used in Parkinson's would be like rasagiline, selegiline, sulfonamide. They can provide symptomatic benefit as monotherapy in early disease, or you can add them on as adjuncts with levodopa if they're experiencing motor fluctuations, similar to COMT inhibitors.
Yeah. The adverse effects for those, we're thinking about like serotonin syndrome. Is still a potential. Hypertension. So if a patient has cardiovascular disease, this would probably not be your go-to. We can also cause depression itself, and worsen other psychiatric disorders. So you have to be really careful with that. But yeah, other than that, the big things we're monitoring are the BP and looking for.
With these, would you still have to avoid tyramine-containing foods for that hypertensive crisis? Is that MAOBs as well?
That's a good question. I'm not 100% sure on that.
I think it is, but don't quote me on that.
It's good. It's good how we were coming up with questions.
Yeah. Somebody will answer
on the
it.
recording. Yeah,
We'll get an email.
I'm sure. I'm gonna look it up before that way I don't get
Right.
By the time I get the email, I already knew that.
Come on.
Everyone knows
that. Was like
that.
so 2 days ago.
People are like, why don't they edit this stuff out? Because we don't edit anything out.
Don't edit anything.
What you get is what you get.
Take it or leave it.
Yeah.
But there are other things you can use, like anticholinergics are used sometimes for symptomatic treatment in combination or as monotherapy. Really, it's for the benefit of the tremor is what you're going for. But a significant portion of patients don't really significantly improve on their bradykinesia or rigidity from these. So it's really just the tremor. Trihexyphenidyl is one you can use. It's indicated more as an adjunct that can be used. Also, benztropine, cogentin. You may recognize that one from your psych rotations. It's frequently used to prevent the side effects from antipsychotics that Mike was talking about earlier. Those are a couple things you can consider.
Yep, and that pretty much covers most of the medications that you'd see for Parkinson's.
Mm-hmm. Sometimes they'll throw in anticholinesterase inhibitors, Aricept, Exelon, rivastigmine patches. I don't know how beneficial that is, but I think it's more for the dementia portion of the Parkinson's.
There's a lot of debate on whether or not those are even all that beneficial in
especially when you're
Alzheimer's
using
and whatnot.
Yeah.
Just because they will improve like the scoring of those certain tests
Right.
that they use, like I'm totally drawing like the MoCA and mini mental status exam, things like that. They'll improve it, but then there's the debate over whether or not those improvements, yes, they are statistically significant, but clinically significant.
Right.
Does
Are
it
they
really make a
actually
difference?
seeing improvements in quality of life from that?
And I've heard it put one way. They basically said that when you're treating that, you're treating the family, because the family doesn't want to see their
Right.
loved one go through that.
So they feel like they're doing something.
They're doing something.
Kind of like with Namenda.
Yeah.
Similar situation maybe.
So yeah, it's definitely a sad disease. But yeah, those drugs I'm a little skeptical of until I see much better data.
It is. But Parkinson's really isn't one that I guess it's not the Parkinson's that really ends up being fatal. I guess the complications from it really long term, like dementia, like inability to swallow or lack of mobility, stuff like that. And people can live with Parkinson's for quite some time. Mm-hmm. It's not abnormal. But yeah, it's a tough disease.
I had one of my professors, or former professors that I look up to greatly, had Parkinson's disease, and had such a good attitude about it. Like you see a lot of depression, and it's a terrible thing to have to live with, but he had such a good and I guess comedic outlook on it. He one time told me he had given himself his insulin, and he was trying to recap his pen needle to put it back in his pocket, and he was having a hard time putting it on. He was like, "Watch this." He goes, "This is the hardest part of my day," and he just started laughing. He's just such a good guy. But anyways,
And speaking of him, so I guess we can talk about some non-medication therapies. So frequently you'd want to refer to physiotherapy or occupational therapy, speech and language therapy, because those are going to be long-term issues. And those can be very beneficial for these patients. Exercising and staying active is very important. As well as in late disease, when the medications have ultimately stopped working, you can consider deep brain stimulation. It's even mentioned in the NICE guidelines for Parkinson's. There was an update in 2017, which I think is pretty cool, something to consider. And I guess they've shown some benefit in those late stages of Parkinson's.
yep, absolutely.
And dietitians would be good, because there's some special dietary considerations, especially when it comes to trouble swallowing and things like that long term.
Yep. What else? We got anything else for Parkinson's?
That's pretty much it. I think that's as brief an overview as you can do for that one, right?
It is. That's extremely brief. So we definitely encourage you to go to like the Piro's pharmacotherapy textbook is the one we like the most. Up to date, Dynamed, whatever you have access to, definitely go check it out, read it in its entirety, and become more familiar with Parkinson's and the drug interactions and some of the other stuff that we didn't necessarily spend a lot of time on. So definitely go check it out. Just to give you guys kind of a quick update on what's coming. We're definitely starting off 2019. We're going to try to get more guests on the show, more experts.
It's the new year, isn't it?
It is the new year.
Wow. Podcast year 3?
No.
Well, I think we didn't release the first one until January.
It was December 17, I think.
Okay. So
we're in year 2.
well, this would be the, 17, 18, 19.
Well,
3 different years.
okay. Yeah, but we'll be bigger by year 3.
Right.
So I'm trying to make it sound. We've been going for 13 months, people.
Yes,
Don't
okay.
listen to Cole.
So
He doesn't know how to
that's
do math.
13 months, 3 years, whatever.
13 months.
We'll say that.
Forget Cole's math. He's
Podcast month 13.
Yeah, there you go, month 13. So it's coming up on January 16th. We're going to have Dr. Eric Meisner on the show, who is an MD, PhD, specializing in infectious disease. And so he is going to come and talk to us about not only his career and give us some insight on how he got to be that smart, but he is going to review some of the HIV, Hep C, co-infections, and treat how he goes about treating some of his patients. So he's going to be really cool to talk to. Got a PA that's going to be coming on talking about endocrinology. We have a psych pharmacy specialist that's going to be coming on and talking about some of the psych meds that we can go a little bit deeper with when he's on. So definitely some more. We're going to have as many people as we can on this year and to really try to blow 2019 up and make the podcast as beneficial as possible for y'all. But definitely appreciate your support, and thank you guys so much for the feedback and everything that you've been giving this past year. We really appreciate you listening. If you do like the podcast, please share it, tell your friends, leave us a comment on iTunes, a rating that helps us out tremendously, and we will keep doing our best to put out episodes. So thank you guys so much, and we will catch you next time. Later.